Testing 1 2. Test 1 2 1 2 1 2. Test 1 2. see the board, bend the road, you see it up there?
Yeah. Good afternoon. Testing. 1, 2, 3. Testing. 1, 2, 3. Good afternoon. You good? Awesome. Thank you. Good afternoon. I want to welcome you to Grand Rounds program this afternoon. A special thank you to St. Vincent's for inviting me to come and speak to you. My name is David Campbell. I am a podiatrist with Foot Specialists of Birmingham. I have been in clinical practice for 28 years. And I chose the topic of diabetic neuroarthropathy. The older literature would refer to this as Charcot foot for two reasons primarily. The first reason is that this particular condition is very poorly reported in the literature. And because it's poorly reported, this condition often goes misdiagnosed, or there's a significant delay in making the diagnosis. And that leads us to number two. When there's a delay in diagnosing this condition, there are very devastating consequences that can happen that frequently lead to amputation. And so the purpose of today's program is to try to create an awareness of this clinical condition and to create within the primary care community certainly a better awareness of the condition. We're all familiar with this data. There's nearly 30.3 million diabetics in our nation today. I think probably the most devastating statistic on this slide is certainly the increase from 98 billion in 1997 to nearly 237 billion in 2017 healthcare dollars spent as it relates to diabetes. The incidence of diabetes has nearly tripled over the last 30 years, and this slide's important because if you notice the red areas, Alabama is a hot spot for diabetes. As a matter of fact, Alabama has the third highest prevalence rate in the nation for diagnosed diabetics at roughly 12% of the population. This past few weeks, I had Dr. Jarzenbeck, one of the residents of the family practice program here in my office, and we were digging out some data. And it turns out that as far as prevalence rate per 1,000 people, Alabama has 6 of the top 10 counties in the nation and 17 of the top 50. So clearly this topic is very relevant to the community and the patient demographic that we practice in. There are nearly 73,000 non-traumatic amputations that happen in our country every year. 60% of those non-traumatic amputations occur in diabetics, and 85% of those are preceded by the presence of a diabetic foot ulceration. And diabetic neuroarthropathy, or Charcot foot deformity, is one of the more common causes for very difficult to manage diabetic foot ulcerations. Financial impact on the healthcare system, $60,000 per hospital stay, approximately $60,000 subacute care once they're discharged from the hospital setting, including prosthetic training and fitting. Today's estimates are somewhere between $180,000 to $200,000 healthcare dollars per amputation in present numbers. But the real price that gets paid for this condition is this right here. Patients that have diabetic neuroarthropathy and undergo an amputation have a mortality rate of nearly 50 to 60% within 5 years. That is higher than for most cancers diagnosed in our country today. So this is a very devastating pathology, and quite frankly, you save a leg, you save a life, and the data supports that. Why is it such a high mortality rate? I wish I had a definitive answer for you. I can only tell you this, that when a diabetic patient develops peripheral polyneuropathy of a sensory nature, and they progress into the motor stages of neuropathy, and then ultimately they experience this preganglionic autonomic neuropathic condition, these patients their prognosis is very, very poor. They don't do well over the course of 5 years. Little historical perspective, Charcot foot was first described back in the 1800s by Jean-Martin Charcot. He described it as a neurovascular condition. Later, it was described by the Germans as a neurotraumatic etiology. So who got it right, the French or the Germans? I'm going to be a little Swedish and say yes. I think they both got it right and assume a neutral posture on that. If I'm going to put a slide up today that's important, this is probably hands down the most important one, because this is the patient as they will present to a primary care setting, urgent care setting, or an emergency room department. Typically, it'll be a diabetic that's younger, third, fourth, fifth decade of life. They'll have the presence of diabetes for nearly 10 to 12 years. They will have a very acute onset of significant swelling, redness, and warmth in their leg. Interestingly enough, completely asymptomatic. They will be insensate to painful stimulus. This is a very insensitive leg. You will not elicit any sharp, dull, pressure, vibratory sensation, or thermal sensation. The onset is usually fairly abrupt. They will tell you that 5, 7, 10 days ago they had a normal looking leg, and they will present to your office obviously very disturbed at the condition of their leg. I have been in practice 28 years, and I think only once have I seen this present bilaterally. It is almost always unilateral. The leg will be at least 10 to 15 degrees Fahrenheit warmer than the opposite extremity, and the pulses in that leg will literally bound your fingers off of their foot, as compared to the contralateral extremity where the pulses will be more normal. An anecdotal symptom, subjective symptom, these patients will frequently tell you they feel like they're having some kind of a deep bone pain, and yet they're insensitive to cutaneous stimulation of painful stimuli. Physical findings, this is where it's challenging, because the way that this presents, there are a number of things, and we'll get to it in a moment as far as our differential is concerned. But I will argue that the physical findings will be present in the absence of constitutional symptoms. These patients will come in, they'll be afebrile, they'll have a relatively normal CBC, maybe 10,000, 10,500. Their SED rate obviously is elevated because this is an inflammatory process. This condition often involves multiple joints. This is not an infection. The diagnosis is clinical, and it's based on recognizing the patient demographic and having a high suspicion for the condition. Certainly our differential diagnosis, probably the most immediate one, if someone were to present into a primary care setting, would be DVT. A simple D-dimer and a duplex scan can rule that out very quickly. Cellulitis, again, infectious or inflammatory. In the absence of constitutional symptoms, it's more inflammatory. Gout certainly has to be considered, probably the most significant one. Quite frankly, when this presents to your setting, you're going to think it's infectious because it looks like an infection. But again, remember that the constitutional symptoms are absent in these patients. And I would argue that in the case of a diabetic foot infection of this severity, you're going to have purulent drainage. You're going to have an opening. And when it comes to osteomyelitis, keep this little peril in mind, is that direct extension osteomyelitis, i.e. from a puncture wound or retained foreign body, first and foremost, you'll have those findings. But even in the case of hematogenous osteo, it is rarely multi-joint. A hematogenous osteo will typically afflict one joint. It'll typically be invasive on one side of the joint more so than the other, but rarely will a hematogenous or direct extension osteo involve 6, 7, 8 joints at the same time. So that, I think, and also the absence of purulent drainage are two things that should probably guide you down the path of considering diabetic neuroarthropathy as part of the differential diagnosis. For my vascular friends out there, May-Thurner. May-Thurner syndrome is actually a condition where the left common iliac vein is traversed by the right common iliac artery, creating an obstruction in venous return that leads to a long-term condition of venous insufficiency. Again, as the differential is used here, May-Thurner is insidious. It's more chronic. The patient typically has been in and out on many occasions with a painful swollen leg. They probably have had a positive DVT or SVT in the past. Again, with diabetic neuroarthropathy, it's acute. It is something that definitively changes within a period of 3 to 10 days. And that's, I think, the most valuable way of differentially diagnosing that condition. Here's the key to preventing amputation. We have to catch the diagnosis early. It has to be caught early. And when it's caught early, the most important component of treatment is to offload the leg. Offloading is up there 3 times because I can't emphasize the importance. If you fail to offload this leg, the foot will become destroyed. And ultimately what will happen is you will develop what the older literature reports as a rocker bottom foot. The normal architecture of the foot of having a very convex shape to it will become complete, or concave would turn completely convex. The calcaneus literally goes into a negative angle and the foot just literally prolapses in the middle. And this leads to a very high incidence of midfoot diabetic foot ulcerations, and those are very, very challenging to treat. And you need to settle in with your patient and have the conversation that when this condition presents, they're in for an 8 to 16 week course of non-weight bearing status until this thing moves into its later stages where they can begin ambulation again. So working definition, it's a progressive non-infectious destruction of bone or joint associated always with the presence of diabetic neuropathy. The sequence of events, patient comes in, painful, or not, excuse me, not painful, other than the deep subjective pain they often have, but a very swollen cellulitic lower extremity, very inflamed and irritated, and failing to make the diagnosis early, unfortunately, leads to inappropriate treatment. That delay leads to the progression of deformity of the foot, the development of the foot ulceration, and then ultimately a partial or complete amputation. The key thing is to recognize that these people are insensate. If you see that they are insensate to painful stimulus, and you see this loss of autonomic control, you've got to suspect the condition again early. Proposed physiology, what happens, it appears to be a neurally regulated vascular inflow pathology that causes the release of significant pro-inflammatory cytokines. One in particular is receptor activator nuclear factor KB ligand, or also known as RANKL. Biopsies from the area that is affected has revealed very high levels of RANKL. And RANKL is important because it is very much involved in the rapid maturation of osteoclast and also rapid activation. And as you are aware, osteoclasts are the cells that break down or destroy bone prior to osteoblastic activity in the case of a fracture that repairs bone. There are classification systems out there. Eichenholz is largely a radiographic classification system. It's based on the three stages that we see radiographically. There are also a couple of anatomical classification systems. Brodsky has one, and then Sanders and Frickberg. I'll allude you to, or refer you to Brodsky's type 1. And the reason that's important is because the Lisfrank's joint is the primarily affected joint in the case of diabetic neuroarthropathy in 80% of cases. Fortunately, only 20% of cases occur in the hindfoot area or in the ankle. So when you have a patient with a very inflamed Lisfrank's joint, medial to lateral side of the foot, that presents with these other clinical manifestations, I think you should have a strong suspicion for diabetic neuroarthropathy. So Eichenholz staging is stage 1, is the stage of fragmentation. If you notice Lisfrank's joint, there's significant fragmentation involved, and it goes from the first metcuneiform joint all the way over to the 5th metatarsal cuboid joint, involves all joints in between. The bone is literally disintegrating with thousands upon thousands of small microfractures. At this stage, this is when the patient presents with an extremely swollen, red-hot extremity. Stage 2 is the stage of coalescence. You begin to see some very early bone remodeling, a little less osteolysis and a little bit more callus formation, but the callus is immature. In other words, it's not really clinically or radiographically stable at this point. Typically, when you reach the stage of coalescence, some of the physical findings and the symptoms, the swelling in the leg will begin to diminish, the warmth of the leg will begin to diminish. You'll begin to see less of those physical findings and symptoms. Stage 3 is a stage of reconstruction or remodeling, and this is the stage that you have to get to before you can start weight bearing again. You'll notice that the bone callus formation is much more mature. You're beginning to see a more organized pattern of trabeculum within the area that's healing. And this is important to recognize because, again, this is the first time that you can consider actually getting these people back to weight bearing. Some of the newer literature that has reported this condition has now come up with a stage 0. And stage 0 is a fascinating concept because this is that earliest stage when all the physical things are present, but most importantly, there's no deformity of the foot just yet. This is when we want to catch the condition. We want to catch it prior to the development of foot deformity. So the keys to making this diagnosis is, number one, you have to recognize that patient demographic. 3rd, 4th, 5th decade of life, most of the time type 2 diabetic, diabetes present and treated for at least 10 to 12 years. That should create a high index of suspicion just by recognizing the at-risk patient. When you get into actually making the diagnosis, certainly we have bone scans. We have technetium bone scans, WBC technetium tag scans. These are great. They're highly sensitive tests, but they're very non-specific. And quite frankly, most of these patients are renally compromised. And so you have to assess the benefits of doing this when it's not going to give you a whole lot of information. And I really hardly ever use a bone scan when I suspect Charcot at this point. I typically go as best I can early in the course to getting an MRI. And again, MRI can be done with or without contrast in this case. And what I'll suggest to you is that in your T1 and T2 weighted images, what you'll see is a lot of medullary edema, especially in the case of Lisfrank's joint, in all of the metatarsal bases and all the cuneiforms in the cuboid. So when you see this intense medullary edema indicating there's an inflammatory process going on and it's involving far more than just one joint, I would argue that in the absence of purulent drainage and constitutional symptoms, this is diabetic neuroarthropathy until proven otherwise. Treatment of stage 1 and 2 is offloading. The gold standard out there, in addition to offloading, is certainly a total contact cast. I am going to tell you that if you've never put on a total contact cast, please don't make it your first. This is a very technically challenging process. It requires literally a contact molding of a cast to the leg in order to effectively work. And as I alluded to earlier, these legs are very much swollen. They have horrible edema, and they're insensate to pain. So you can slap a cast on these people, and when you take it off in a week, you will see a wound that is so devastating that, quite frankly, I've seen several cases of a total contact cast that led to amputation before the patient ever had a chance to be salvaged. So you have to be very careful. I personally do not prefer total contact casting. I go to option number 2, which is a lower leg walking boot with a heat moldable inlay. And again, the most important thing is non-weight bearing. So I typically recommend like a tricycle. You see those little tricycle scooter things that a person puts their knee on, and it allows them to get around a little easier. In the case of this patient demographic, they frequently have metabolic syndrome, which means they're obese, along with all the other medical problems. And with the obesity, they have a hard time managing crutches for 8 to 16 weeks. So these little appliances, these scooters, work quite well. As far as pharmacological management is concerned, biphosphonates have been attempted. I will tell you that there's absolutely no evidence-based medicine that biphosphonates are helpful at shortening the course of diabetic neuroarthropathy. Treatment of stage 3, once you get them to the point where they can weight bear again, if we've done our job and done it well and we've caught them early and there was very minimal destruction of the foot, quite frankly, a really good technical level running shoe with some heat moldable multi-density inlays in the shoe can often keep this patient from developing a diabetic foot ulceration. In the case where the patient has progressed to a foot deformity, I would argue that a custom molded shoe, in the case where the deformity is not horrible, could be effective. But in most situations, we'll use an appliance called a crow, which is a contact or a Charcot restrained orthotic walker, or, and I was just speaking with Don, what is the name of the company, Biotech? Yeah, I use that guy a lot. I like to use a clamshell style double upright patellar tendon weight bearing brace attached to a shoe. It effectively functions a lot like a prosthetic leg, except for they keep their leg. It basically transfers the pressures on the sole of the foot up to the patellar tendon and allows the patient to ambulate almost as if they have a prosthesis. I will tell you that once a patient develops diabetic neuroarthropathy, they require a lifetime of surveillance. They're never out of trouble. They require ongoing care, and you have to watch the insoles in their shoes. You've got to watch the appliances, whether you choose a crow or a clamshell-styled brace. You have to constantly monitor the materials for fatigue, and you got to quickly replace them because these patients are always at risk. This is just an example of some of the multi-density type insoles that we'll often put into a patient's shoe. This is a custom molded shoe with a special Aliplast Plastizote insole. This is an Arizona brace. Can be helpful in certain cases of Charcot. My feeling is I've not had a whole lot of success with Arizona braces for this particular condition. This is an example of a crow, a Charcot restrained orthotic walker. You can see that the entire boot is lined with a special diabetic material called Plastizote and Aliplast. And it functions a lot like a total contact cast in that it is molded literally to the patient's leg and provides a total contact situation during weight bearing, which reduces high pressure points and subsequently reduces the risk of diabetic foot ulceration. This is kind of an example of what it looks like with the patient's foot in it. This is a clamshell style double upright patellar tendon weight bearing brace. Again, that's probably my mainstay for managing these patients because they're in this appliance for the rest of their life. There's no getting out of it. This is an example of a total contact cast. This is actually a kit that comes to your office. You'll notice that there are pads for the malleoli, and then there's a pad for the tibial crest, and then subsequently this is a fiberglass material that is used to create the total contact. And this appliance is actually used in combination with a lower leg walking boot. Uses a kind of a combination of the two. This is probably a pretty decent product. I've used it. But again, I tend to avoid casting these people, especially in the earlier stages. This unfortunately can happen inside a total contact cast. This is a pressure ulcer that happened over the lateral malleolus. And this is actually down to bone. You can actually see the exposed bone there. This is not what you want to see when you take off a total contact cast. This can have devastating consequences for the patient as well. Just some examples. This would be an example of Lisfrank's involvement. This is an example of mid-tarsal joint involvement. You can see, I don't know if you can see the red line here, but it demonstrates a reverse in the calcaneal inclination angle and gives you an idea of the rocker bottom or the collapse that happens. You can only imagine how prone the patient is in this area to developing a diabetic malperforans ulcer, one of which will be very challenging actually to treat and maintain. Here's another example in a patient that's had a 5th ray amp, but you can see complete involvement involving Lisfrank's joint. This is probably very typical of the most common pattern that you would see in a clinical setting. Another example, this guy's had a 4th and 5th ray amp, and you can see what happens down the road. He's got a fractured 3rd metatarsal. Actually, if you look closely, you'll see some black area here and here. This guy came into my office not long ago. His metatarsals were out of his foot. He was literally walking on his bones exposed through these ulcers that he had had for quite some time. I have good news though, this guy is closed now. So we cleaned him up and got his ulcers taken care of. I used a product called Apligraph, which is kind of a synthetic biologic, and it is actually neonatal foreskin on a bovine collagen matrix. and so it has live cells to it, which is nice, and it helps to kind of get a wound going again. Same patient. This was him before closure. So, and I wish I had the immediate ones. One of the residents was with me when he came into the office, actually, and he looked at the foot and said, "Is that what I think it is?" And I said, "Yeah, that's his metatarsals." And this was him about 6 weeks ago, and now good news is everything's closed, and he's in a brace that we looked at earlier. So just kind of an example of what that foot looks like, down the road. Very broad, flattened, and unfortunately prone to ulceration. This is another example, 2 very high-risk areas for diabetic malperforans ulcers. This is an unfortunate circumstance. The cuboid has been extruded through the plantar aspect of the foot. The navicular is completely dislocated off the head of the talus. You can only imagine what these patients are like to manage long term. Surgical intervention does exist. I would have to tell you that surgical intervention has to be planned extremely carefully in these patients. The goal should always be to reduce pressure, prevent ulceration, and ultimately reduce the risk of amputation. One of the biggest risk factors with these patients, surgically speaking, is compliance. Because the attack on these patients involves use of a lot of hardware, either internal and or external fixation, and sometimes even a combination of the both. And you have to certainly consider all their comorbid medical problems that accompany this patient demographic. Surgical procedures, tendo-Achilles lengthening is very important. These patients develop a very bad, what's we refer to as an equinus, in other words, an extremely tight Achilles tendon. That causes some really abnormal forces across the mid-longitudinal arch of the foot and subsequently collapse. I think it's probably why Lisfrank's joint collapse occurs so often, because the tendo-Achilles is so actively involved, and if you're going to address these cases surgically, you're almost always going to have to do a tendo-Achilles lengthening on these patients in order to reduce those plantar-grade pressures. And this is just a quick example of some internal reconstruction, mostly in first met cuneiform joint and central encapsulation of Lisfrank's joint. This is an example of an external fixator, all of which are very viable options. Certainly the goal today, my goal as having an opportunity to get in front of a lot of primary care was to create an awareness of this condition so that you can have a high degree of clinical suspicion when this patient presents, because quite frankly, if you do that and you do it well and you get them properly cared for, in other words, we do our jobs well together, we can certainly prevent amputation. And as we saw the data earlier, preventing the amputation ultimately in this patient population saves their life. So with that, that is the end, and I'll be happy to entertain any questions that you might have. Yes, sir.
Is hyperbaric treatment of any success?
Hyperbaric is a definite adjunct to wound care, for sure, especially when we have diabetic foot ulcerations. And certainly in a diabetic foot ulceration where the patient's vascular situation is compromised, and maybe the patient's not a great candidate for vascular intervention, I think certainly in the right patient selection, hyperbaric therapy can be very beneficial in managing some of these wounds. I would also argue at the same time, though, I don't really care what we do to the wound, whether it's hyperbaric oxygen or an aplograft or some other amazing biologic. Now we're having mesenchymal cells and amniotic products that are coming out. And I'm just going to tell you, you don't get the pressure off these wounds, they don't close no matter what you do to them. So again, that offloading principle has to be the key component to it, and then you can certainly add adjuncts to it, hyperbaric therapy, biologics, skin cell replacement. Any of those products can certainly be beneficial. Yeah. Anybody else? Yes, sir.
What percentage of these get infected?
Man. Any answer I give you would be anecdotal. But in the case of midfoot collapse, the ones that we actually saw, I don't think, I would tell you that I don't think an infection, I think it's almost imminent. You can only close these ulcers so many times before the bacterial load in that wound is so measurable that you end up in an infection. Yeah, so I would say anecdotally over time, all of them. unfortunately. And you know what makes this condition so challenging is that we see a lot of digital deformities secondary to the motor neuropathy. You know, you see rigidly contracted hammer toes that result in diabetic ulcers under the forefoot. Well, we can take that patient in when they're medically stable and fix those contractures and get the pressure off of those wounds. But once you have a midfoot collapse like this, you just don't have that option. You either have to do the major reconstruction with internal and external fixation or a combination of the above, or you have to do everything you can clinically to keep these patients from ulcerating. Anybody else? Yes, sir.
Are there any type of data that suggests a misfitting of some of the orthopedic devices, the offloading devices, previous to the neuropathy actually being a causation to the neuropathy?
So you think
they've been misfitted and they didn't have the neuropathy before for some other reason. Is there anything that suggests that the neuropathy can actually be caused by mistreatment?
I would say no. By and large, no. Can you have a patient have an adverse neurological outcome secondary to a cast that's too tight around the knee and puts compression on the common peroneal nerve? Absolutely. And that would certainly be an iatrogenic situation. But when it comes to this particular patient population, you know, the neuropathy is a result of the presence of diabetes over time, and that is really the underlying pathology. Anyone else? No? Well, again, thank you very much. Oh, I'm sorry, we have one more.
When you do the amputations, do they have to be at the joint because of the involvement of the marrow at the bone? Or?
Yeah, I will tell you that if I have any suspicion at all that the bone is infected, it's coming out. I'm going to do, and the interesting, I'm glad you asked that question because quite frankly, what happens with many of these cases is that you'll have great intentions in one area and you'll subsequently end up with an ulceration in another area. And so you literally, I think that you plan the amputation at an appropriate level that gives the patient optimal outcome, but at the same time reduces their risk of getting a transfer lesion into another area.
Does it have to be at the knee or can it be?
I will tell you this, to date, unless there's something out there that I'm not aware of, the greatest challenge with an amputation at the level of the ankle is the fitting of a suitable prosthesis. I think once, and anyone else has anything to chime in, that I'd be welcome your input, but I think that once you get beyond the mid-tarsal joint and you get into the ankle area, I believe that from a prosthetic perspective, it's far easier to do a below-the-knee amputation because it's easier to train on a prosthetic. And I would argue that the long-term outcome is probably no different. Anybody else? No. Thank you very much for having me this afternoon, and I hope you all have a really blessed day.